Hello, and welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this module is another part of the series on physician payment systems entitled Pay for Performance, Part 1. This module is targeted to Level 3 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, please reference the Replete resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to describe the drivers of initiatives to increasingly base physician payments on a variety of quality and value metrics, to outline the history of Medicare's physician pay-for-performance initiatives, and to identify tactics to optimize individual physician success under current and anticipated pay-for-performance models, and inform the development of more robust future models by both payers and professional societies. Here are some additional resources listed alphabetically by author for those who would like to learn more about the topics in this module. We talked previously about the evolution of physician payment systems from fee-for-service to pay-for-performance and accountable episodes, and our plans to present each of these framework models to you in a series of modules. In the prior two modules, we focused on fee-for-service, the historic, largely volume-based matter in which Medicare and most other insurers have compensated physicians for their services. In this module, we will discuss pay for performance, or P4P, which you'll see in a lot of my slides. That reflects, in the eyes of many stakeholders, a far preferable way of compensating physicians for their services and aligning their financial interests with those of individual patients, other providers and health systems, and the population at large in promoting higher quality and lower cost healthcare. In Part 2, we'll discuss how these programs have performed to date and highlight as well opportunities to improve these programs as they all move forward. Let's start with some definitions. What is pay for performance? It's a form of value-based purchasing which financially incentivizes provider behavior using bonuses and/or penalties that can be graded or binary, in which payments are dependent upon a specific desired service characteristic or series of characteristics, and those frequently boil down to appropriateness, outcomes, service, and cost. Why those four, you might ask? Well, remember, as I told you before, these are the various components of value, and this is a value-based payment system. Value is enhanced when outcomes are improved, when service is improved, when appropriateness is optimized, and costs are reduced. And so the goal is to incentivize each and every one of those components. How payments for physician, and most other healthcare services for that matter, get determined is a complicated process that varies from patient to patient, depending upon their insurance, region to region, and from payer to payer. In the days prior to healthcare insurance, the free market ruled. That is, price was determined by the supply of services as well as the demand for them. In a single-payer world, at the other extreme, that single payer determines payments in any way it may seem fit. Let's talk about those extremes, recognizing that reality lives somewhere in between and is always changing. Remember when we talked about the development of RBRVS, I told you that Medicare initially based its payments on UCR methodology. That's usual, customary, and reasonable. That methodology considers market-to-market variation. For example, what may be reasonable, usual, and customary in, say, New York City may be very different from that in Lincoln, Nebraska. And it also considers intra-market variation, the size of an individual group, the size of a health system, or the clout of a specific specialty within an individual region. Ideally, if patients are paying cash, they know what they're getting in return as they do when they buy a car or a house or a computer. Then those payments would ideally be value-based. But we've previously talked about the transparency barriers that often prevent that from happening. At the other extreme is one-size-fits-all, government-imposed pricing. This is RBRVS in many ways, where payments are determined based upon a rigid formula imposed nationally that considers what it costs to provide a service rather than what value that service brings to a patient or a population, or whether that service is necessary at all. And so in Medicare, we've seen an evolution from UCR, when the program was created in the mid-1960s, to RBRVS, which went into place around 1990, to a number of pay-for-performance initiatives that began to be discussed around a decade later. And those are the PQRI, the Physician Quality Reporting Initiative, the PQRS, the Physician Quality Reporting System, and MIPS, the Merit-Based Incentive Payment System. For Medicare physician payments, it is essentially these three programs you see listed here that folks mean when they talk about pay for performance. So let's talk about each one of these briefly. Pay for performance for Medicare Part B physician payments really came into effect in 2007 when Medicare introduced the PQRI, the Physician Quality Reporting Initiative. It was a prototype system and purely voluntary, and rewarded physicians as much as a 1.5% bonus on their Medicare payments for their performance in reporting a number of discrete measures. It's important to note that while these measures were pretty focused, the 1.5% bonus applied to all of their Medicare payments as a lump sum about a year later, rather than a bonus on just the affected services. 3 years later, that system was codified and went from an initiative, that's the I in PQRI, to a formal payment system, hence the S in the name PQRS, Physician Quality Reporting System. This started out as a bonus system, with the bonus jumping from 1.5% to 2.0% and remained voluntary. But over the next several years, it changed to a penalty system in which you didn't get anything for participating, but you got a penalty of as much as 2.0% for not participating. That effectively means that the program became mandatory. But, like PQRI, the payment adjustments were all unidirectional. That is, you either got a bonus or not in the earlier years, or a penalty or not in the later years. This all changed a bit more under the Medicare Access and Children's Health Insurance Program Reauthorization Act, that's MACRA, of 2015. Beginning in 2017, then, related to that legislation, a few things happened that we'll talk about in more detail in an entire module down the road on MACRA. First, the system became mandatory for nearly all physicians. Well over 95% of radiologists are anticipated to have to participate in MIPS. Second, the stakes got a lot bigger. Instead of just small adjustments on the order of 1 to 2%, under the fully phased-in program in year 2022, bonuses and penalties will be as large as 9% of a physician's total Medicare payments. We're talking some big dollars here. And third, the adjustments will be bi-directional. That means there will be losers and there will be winners. And the dollars to be paid to the winners will be coming from the dollars taken from the losers in a largely budget-neutral manner. Although we're focusing on Medicare here, because Medicare's programs have gotten the most attention, remember that I told you early in this module that pay-for-performance programs aren't always graded like PQRI or PQRS or MIPS. They can be binary. While nobody really calls these pay-for-performance programs, they are, and pay-for-performance initiatives are all over the place. Take, for example, state licensure. If you're not licensed to practice, no payers will pay for your services. And there are some legislative initiatives in a few states that are brewing now, pushing to make your maintenance of certification mandatory, meaning that if you don't dot your I's and cross your T's related to whatever a certifying board wants you to do each year, your license might be in jeopardy. And so, no maintenance of certification participation could mean no ability to bill payers. And the same applies to facilities as well. If your hospital isn't part of a payer's network or didn't get XYZ accreditation, many payers simply will not pay for those services there. Again, binary. But facilities can be also paid in a graded manner as well. Although I'm focusing on physician pay-for-performance systems in this module, our hospital partners also participate in a number of other graded programs, which include the Hospital Outpatient Efficiency Measure Program, something we'll talk about in the next module with regard to double CT scan studies. I've taken a high-level and somewhat theoretical approach so far in describing pay-for-performance. Let's take all of this variation in physician payments from the theoretical into a real-world example. Let's talk about how you might get paid for performing a PICC line under a variety of payment models. You know by now how to calculate national Medicare average payments using the Medicare fee schedule lookup tool. We'll talk about interventional radiology component coding in a special add-on module later. But suffice it to say that when you perform a PICC line, as most of us do, you actually bill out 3 services. There's the PICC line itself, CPT code 36569, which pays about $88 to $89. There's the ultrasound guidance that you use to achieve your access, CPT code 76937, which pays you about $15. And the fluoroscopic guidance you use to navigate the catheter centrally, CPT code 7701, which pays you about $19. And in total, that gets you a bit more than $100 in payments from Medicare. So let's say for the purposes of this illustration, that's the average price for this service. Depending upon the market and the provider and the patient, however, physicians can get paid quite differently for that same group of services. Let's illustrate this all with 10 hypothetical doctors, ranging from Dr. A to Dr. J. In a pure free market, which we know does not exist in the healthcare system in the United States, physicians say bill whatever they get paid. And so payments may vary wildly, some well above that average payment and some well below. At the other extreme, under pure RBRVS, everybody gets paid the same, whether their outcomes are better or worse, their services to the patients are better or worse, or whether they are appropriately judicious in their patient selection in performing procedures. Under PQRI, where you could unidirectionally receive a tiny bonus if you checked all of your performance boxes, you could get a very modest bonus of about 1% or so, barely noticeable as the taller lines on this graphic. And then when that went to PQRS, nobody got paid more than the RBRVS determined payment in the later years, but some, as you see here, got paid about 2% less. Again, not too noticeable in light of total payments. But what about MIPS? Remember, MIPS will be bidirectional, and with adjustments as large as 9%. So you could see variation, some at 109% and some at only 91% of RBRVS, like I've illustrated here. In reality, though, few physicians will perform so well that they get all 9% of their maximum potential bonus, and few will perform so poorly that they got all 9% of their potential maximum penalty. So, I think we'll wind up seeing a range of payment amounts based upon how well or poorly physicians did in reporting all of these metrics, not dissimilar to what you see illustrated here. And as you consider these variations in payment, it is important to remember that while value is based on outcomes and service and cost and appropriateness, there are really no validated, robust, and transparent ways to measure all of these for radiologists at present. So in reality, pay for performance, and in particular MIPS, isn't as much about paying for real quality. Right now, unfortunately, it's much more about paying for the quality of your reporting of the metrics that CMS wants you to report. If you want to do well under these programs at present, you will, a bit sadly, have to develop a bit of a box-checking mentality. But as you do that, keep in mind that the educational and operational initiatives that you work through that allow you to do well under our current rudimentary pay-for-performance systems will also prepare you for success when these systems get even more complicated. So the time to start is now. In the next module, we'll take a deeper dive into PQRI and PQRS and MIPS, and we'll talk about how radiologists have performed under various pay-for-performance systems to date. I think that history lesson will help you better prepare for the new and emerging systems with which you will soon need to comply. So in summary, physician pay-for-performance systems are forms of value-based purchasing intended to incentivize both higher quality and lower cost care. Despite their theoretical appeal, like fee-for-service, such payment models are not without some challenges. At present, Medicare pay-for-performance systems reward physicians for the quality of their reporting, sometimes more so than the reporting of actual quality. Given clear stakeholder imperatives and increasing dollars at stake, radiologists must work to make their participation as meaningful as possible at both the individual practice level and broader specialty levels. We'll talk about those more in the next module. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the RIPLEAD initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in RIPLEAD.